Welcome to the introduction to the 2018 Diabetes Canada Clinical Practice Guidelines for the Prevention and Management of Diabetes in Canada. My name is Dr. Robin Holden. I am Professor and Chair of the Division of Endocrinology at Queen's University and had the pleasure of acting as Chair of the 2018 Diabetes Canada Clinical Practice Guidelines. The International Diabetes Federation has identified diabetes as one of the largest global health emergencies of the 21st century. Each year, more and more people worldwide are diagnosed with this serious chronic condition with potentially devastating complications that affects all age groups. In 2015, the IDF estimated that 415 million adults currently had diabetes and 318 million adults had impaired glucose tolerance, putting them at high risk of developing the disease in the future. In the study shown in this slide, compared with the prevalence of diabetes in European, American, and Oceania countries, the rate for Canada was the third highest at 9.2%. The prevalence of diabetes varies across Canada. In 2008-2009, after accounting for differences in age distribution among the provinces and territories, Newfoundland and Labrador, Nova Scotia, and Ontario had the highest prevalence of diagnosed diabetes, while Nunavut, Alberta, and Quebec ranked lowest. The proportion of people with diagnosed diabetes generally increases with age. The sharpest increase in the prevalence of diabetes occurs after the age of 40. In 2008-2009, the 75 to 79-year age group had the highest proportion of people with diagnosed diabetes. Although diagnosed diabetes is more common in older age groups, more than 50% of the affected Canadian population, 1.2 million, was of working age between 25 and 64 years. The age-standardized prevalence of diagnosed diabetes among Canadians aged 1 year and older has increased by 70%, from 3.3% in 1998-1999 to 5.6% in 2008-2009. Prevalence over time was consistently higher among males than among females, but increased in every age group. The DM SCAN study was performed to gain insight into management of patients with type 2 diabetes by Canadian primary care physicians. 479 primary care physicians from across Canada submitted data on 5,123 patients with type 2 diabetes, whom they had seen on a single day on or around World Diabetes Day, November 14, 2012. The mean A1C was 7.4%, mean LDL cholesterol was 2.1 millimoles per liter, and mean blood pressure was 128/75. An A1C target of less than or equal to 7% was met by 50%. An LDL cholesterol target of less than or equal to 2 was met by 57%. A mean blood pressure target of less than 130/80 was met by 36%. The composite triple target was met by only 13% of patients. Nutritional counseling had been offered to 38% of patients. Of the 87% prescribed antihyperglycemic agents, 18% are on one non-insulin antihyperglycemic agent, and for the majority this was metformin. 15% were on 2 agents, 6% were on 3 or more agents, 19% were on insulin only, and 42% were on insulin with 1 or more non-insulin antihyperglycemic agents. The DM SCAN survey highlighted the persistent treatment gap associated for treatment of type 2 diabetes and the challenges faced by primary care providers to gain glycemic control and cardiovascular protection in these patients. The Diabetes Canada Clinical Practice Guidelines are intended to provide guidance on the most appropriate management for people with diabetes. They are meant to enhance diabetes prevention efforts with the goal of reducing the burden of diabetes-related complications. They are also meant to inform clinical decisions made by healthcare providers. I would like to provide a quick history of the guidelines. The first set were published in the Canadian Medical Association Journal in 1992 and were only 16 pages long. They were chaired by Dr. Ming Tan, and the recommendations were not graded. Here is the pharmacologic glycemic management algorithm for these guidelines. The image highlights that treatment choices were limited at the time. The next set of the guidelines were published in 1998 and were co-chaired by Dr. Sarah Meltzer and Dr. Larry Leader. They were 29 pages long and contained 93 recommendations with grading. Here is the pharmacologic glycemic management of type 2 diabetes figure. Once again, it highlights that limited treatment choices were available at the time. The next set of guidelines were published in 2003 and were published in the Canadian Journal of Diabetes. They were chaired by Dr. Stuart Harris, and Dr. Herzl Gerstein chaired the Methods Committee. They were 163 pages long and contained 154 graded recommendations. The pharmacologic glycemic management of type 2 diabetes figure shows the availability of more treatment options and the need to make timely adjustments to therapy to reach A1C targets within 6 to 12 months. The next set of guidelines were published in 2008 and were chaired by Dr. Vincent Wu. Dr. Gillian Booth chaired the Methods Committee, and Dr. Ian Bloomer chaired the Dissemination Committee. The guidelines were 201 pages long and contained 213 recommendations. Dr. Alice Chang chaired the 2013 guidelines. Dr. Gillian Booth continued in her role as chair of the Methods Committee. Dr. Catherine Yu took over the role as chair of the Dissemination Committee. The expert committee included 120 key stakeholders, and the guidelines contained 240 recommendations. This version of the guidelines saw the development of a website that housed the full-text guidelines as well as many innovative practical tools. The 2018 guidelines involved 135 healthcare professional volunteers from across Canada. Dr. Diana Sharafelli and Dr. Doreen Raby acted as co-chairs for the Methods Committee. Dr. Catherine Yu continued in her role as chair of the Dissemination Committee, but was joined by co-chair Dr. Noah Ivers. This set of guidelines is the longest ever at 325 pages and contains 317 recommendations. The website has been enriched with even more practical tools and resources for healthcare providers and people with diabetes. The 2018 guidelines were released on April 9, 2018 and are housed on the Diabetes Canada website. In addition to the full guidelines, various tools and resources are present and are updated regularly. Only medications with Health Canada Notice of Compliance granted by September 15, 2017 were included. This slide demonstrates the committee structure used for guideline development. There was an executive committee consisting of the chair, 2 past chairs, co-chairs of the Methods Committee, and 3 experienced guideline developers. A steering committee consisted of members of the executive committee with 7 subgroup chairs, co-chairs of the Dissemination and Implementation Committee, 10 senior advisors representing a variety of allied health professions including primary care, endocrinology, pharmacy, nursing, dietetics, cardiology, and pediatrics, as well as 2 informed patients living with diabetes, 1 with type 1 and 1 with type 2 diabetes. An expert committee consisted of 135 healthcare professionals who were nationally recognized content experts for their chapter. The guidelines development process was supported by an executive editor, Diabetes Canada support team, and the McMaster Evidence Review and Synthesis Center. The guidelines underwent external review by national and international reviewers and included specialists, community primary care providers, academic departments of family medicine across Canada, and specialty and disease support organizations. An independent methods review committee ensured consistency and rigor in the recommendation development process. The IMR consisted of 9 university-based clinical faculty with advanced training in research methods. The IMR provided methodological expertise and were a resource available to the expert authors throughout the development process. A dissemination and implementation committee consisting of 2 co-chairs and volunteers developed strategies to increase healthcare practitioner implementation of the recommendations. A major activity of the guidelines was the development and maintenance of a guidelines website, which hosts the full guidelines, interim updates, a quick reference guide, key messages for healthcare providers and people with diabetes, healthcare provider tools, slide kits, videos, and webinars, as well as resources for people with diabetes and their support systems in a variety of languages. Both iOS and Android apps were also developed. The guidelines are not meant to provide a cookbook approach to diabetes care where the clinician has no discretion. In addition, they are unable to provide guidance in all circumstances and for all people with diabetes. People with diabetes are a diverse and heterogeneous group. Treatment decisions must be individualized. Guidelines are meant to aid in decision-making by providing recommendations that are informed by the best available evidence. However, therapeutic decisions are made at the level of the relationship between the healthcare provider and the individual with diabetes. That relationship, along with the importance of clinical judgment, can never be replaced by guideline recommendations. Evidence-based guidelines try to weigh the benefit and harm of various treatments. However, patient preferences are not always included in clinical research, and as a result, patient values and preferences must be incorporated into clinical decision-making. Some of the key changes to the 2018 guidelines were the expansion of the expert committee to include 135 healthcare professional volunteers from across Canada. There was broader representation from more allied health interprofessional stakeholder groups, who brought expertise from diverse practice settings across the country. They included professionals from family medicine, endocrinology, internal medicine, cardiology, neurology, nephrology, infectious disease, urology, psychiatry, psychology, obstetrics, ophthalmology, pediatrics, nursing, dietetics, pharmacy, chiropractics, exercise physiology, and others. Other key changes included the inclusion and active participation of informed people with diabetes on the expert committee. Each chapter contains key messages for healthcare providers, as well as key messages using lay terms directed at people living with diabetes. Here is an example from the Diabetes and Driving chapter. These are the key messages for healthcare providers. And these are the key messages for people with diabetes. As you can see, they are written in lay terms. Another key change in the 2018 guidelines is increased recognition of ethno-cultural diversity in Canada and its relationship with diabetes care. There was increased involvement of Indigenous authors and organizations and healthcare providers working with Indigenous populations and communities in the development of recommendations related to type 2 diabetes in Indigenous people. The guidelines also acknowledge the legacy of colonization in residential schools and their ongoing effects on Indigenous health, as well as the calls to action of the 2015 Truth and Reconciliation Commission. The guidelines also contain new material on diabetes and driving, as well as post-transplant diabetes. The introduction chapter contains information related to diabetes and oral health, as well as diabetes and cancer screening. A key change in the 2018 guidelines was that a more rigorous systematic review of the literature was performed with the McMaster Evidence Review and Synthesis Center. In addition, there was a more rigorous review of the grading of recommendations by the Independent Methods Review Committee. At the end of each chapter is a literature review flow diagram illustrating the systematic review performed for each chapter. This is the diagram for the entire guidelines. Over 600,000 articles were originally identified. After screening by reference librarians, 8,030 articles underwent full-text review by the chapter authors. The authors completed grading sheets using a program called Distiller, where they had to justify why a reference was excluded or included. At the end, 323 articles were used to support new or revised recommendations. Other key changes were that a wider external review was performed by specialists, community primary care providers, academic departments of family medicine, and specialty and disease support organizations. Additional efforts were made to manage and minimize conflict of interest among all expert and steering committee members. Author disclosures are listed at the end of each chapter. There was expanded harmonization of recommendations through collaboration with other organizations, including the Canadian Cardiovascular Society, Hypertension Canada, and the Canadian Cardiovascular Harmonization of National Guidelines Endeavour. There was also expanded dissemination and implementation strategies to support all the recommendations with increased use of web-based technology. And I encourage you to visit the Diabetes Canada website, and you can also obtain all the same information by downloading the app. A key message throughout the guidelines remains the importance of individualizing therapy for the person with diabetes. I will go through the next few slides quickly, but want to acknowledge the hard work and support of my talented steering committee listed on the next few slides. I truly did what this slide states. I surrounded myself with dreamers and doers, believers and thinkers. I encourage you once again to visit the Diabetes Canada Guidelines website, where you can view full versions of the guidelines, download slide kits and videos, find a variety of healthcare provider tools as well as resources for your patients. And the same material can be found by downloading the app. I would also like to thank all of the expert authors who contributed uncountable hours of work. We can all be proud of these world-class guidelines that have been created.